Pull up your slide.
Oh, yeah. Okay, so our next discussion this afternoon is going to be treating MS, the disease and the symptoms of multiple sclerosis. So what I'm going to talk about, what is MS, how do you treat it, what are the symptoms, how do you treat them, and what is the future. So, although you're not going to be probably the most center of their treatment, we are going to be seeing patients in primary care with this diagnosis. We are also going to be alerting neurologists if there's a change, or we're going to be involved in seeing patients because it affects young women between the ages of 20 and 40 predominantly. So it's the most common chronic disease affecting the central nervous system in young adults. 400,000 cases in the U.S., 1 in 1,000 in the general population. 2.5, and I did verify that worldwide. It looks like the ancestry is European with Caucasians having in women 2 to 3 times more prevalence. 3/4 of the patients that present with MS are between the ages of 20 and 50. So this is a worldwide slide of the worldwide distribution, so you get an idea of what we're looking at. There are areas of other risks that the white or not very probable low risk, but you see that we live in North America and the part of the world where there's a high risk of multiple sclerosis. So what are potential triggers? Infection, genetic, environmental, all leading to an abnormal immunological response. It is a chronic, progressive, unpredictable disease of the spinal cord and brain caused by autoimmune attack on the axons and the myelin. We see there's different types that are characterized, relapse and progression and disability over time. So we look at the patient with MS having inflammation, demyelination, and axonal damage to the nerves. That's the problem. So this would be an example. This illustration is an electrical signal and how they should be conducted. And myelin coating makes electrical conduction faster. So that myelin sheath, this part, the nerve fiber makes it move right along to the cell body and do the work. In MS, it's damaged. And peripherally acting immune cells disrupt the blood-brain barrier, enter the central nervous system, recruit other immune cells that attacks and breaks this down. So you'll see the B cell, the T cell, and that's in the periphery. Then you start seeing that myelin sheath wearing away and breaking down. And then you see the cytokines and the inflammatory process and the sclerosing happen. Axons with damaged myelin cannot conduct electrical signals effectively. So here is a slide that was brought up on this side of the screen. Whoops, went too fast on myself. Axons with damaged myelin cannot conduct electrical signals. You see how it's all broken down and frayed compared to that nice healthy one I had you see in the beginning? The difference, right? The wiring's getting bad. Problems start to ensue. So it is a clinical diagnosis. It requires an abnormal MRI, which is the gold standard of testing. Dissemination of space and time. We find no other explanation for their clinical and paraclinical findings. Now this slide speaks to the most common symptoms, and you can see a variety of symptoms. These percentages were based off of one diagnostic article or article finding. I've seen varieties in different articles, but I just would caution you, the patients that you're going to see are going to have bladder dysfunction, heat intolerance, pain syndrome, and sensory syndrome, sometimes the visual loss, also known as optic neuritis. Sometimes they say 14% multiple symptoms at onset. That's when it gets kind of tricky. You don't know, is it central, is it peripheral, do they have more than one thing? So here would be inflammatory white matter lesions depending upon the location that results in neurological problems. So slide A shows you where everything enhanced, the white, okay? So you look for these little pinpoint lesions. That's what ends up telling you where their problem or their focus of their problem. So why does one guy have spasticity? Why does one guy have bladder problems? Why does one gal have this or that? It's because of the location in the lesion or the spinal cord. That's what drives the symptomatology, okay? So Dr. McDonald was a provider, I believe, who developed the criteria for MS. Although a diagnosis can be made on clinical grounds alone, MRI findings need to support it, space and time. That means you have one event a year, you have one every 6 months. Either diagnosis of MS with high degree of specificity and sensitivity. The earlier it's made, the earlier we intervene might be better off for the patient, right? So what do we do to treat these relapses and disease-modifying therapies? So when you think about that wire I was showing you, the neuron, it's breaking down, and this inflammatory process, immunological changes are happening. If we don't disrupt that, we lose more and more, right? That we can't get back, and that causes more disability. So goals of disease management include treating the relapses, managing their symptoms, modifying and reducing relapses, and delaying progression. You know, and I see a whole gamut of patients on a spectrum. I see the guy or gal not on any meds, doing fine, and then I see the patient, no matter what we try, they keep progressing, and they keep going. So there's different categories. In a nutshell, the evolution in the treatment is sometimes episodic care, supportive management, symptomatic intervention, clinical trials, and even since I did these slides last, 2 or 3 drugs. One drug got taken off clinical trials. 2 new ones were released, and one that was just on the fringes of getting approved was approved. So I've got a student in the class who's just reading away over there. So we have these what is the goal of modifying our therapies? We aim to alter the course of it, decrease relapses, delay disability, and we use primarily 2 classes of drugs, immunomodulators and immunosuppressants. So here are the lists without beating these names up. We've had the beta serum, the Avonex, the Rebev, the Copaxone around for a while. You guys have heard those names, have even had patients on them. Family members maybe. The Sabre, Gilenya, Albazio, and the Tecfidera are kind of newer ones around, as well as Plegridy. So they have different selective and non-selective immunomodulation that takes place. And if you were going to be prescribing these, I would go more into what they do and what they don't do, but I just wanted you to know the names. Some non-specific immunosuppression, we still do use our fair share of corticosteroids. I don't see so much Cytoxan or cyclophosphamide used anymore, or mitoaxatrone, but I'm saying that right now I have one patient on Plegridy, I have one on Copaxone, and I have one on Sabre, one on Rebif, one on Avonex. So you see how there's a gamut of patients that like or tolerate or do better on, depending upon how their MS prognosis, diagnosis, and classification is. Other therapies, Lamentrata, is that what you just mentioned?
No, this is Dendrita. It's Daclazumab.
Yeah, I'm going to, at the very end, I have a slide on progression of research. So acute MS relapses, that's what we're trying to avoid. and keep them out of relapsing. So what a relapse would look like is they start having focal disturbances of function for more than a day. In some people, they occur about once a year in the absence of everything, there's nothing else provoking it, okay? Sometimes we just manage it. We give them high-dose steroids. We knock out the episode. They get back on track. They're fine. If they're refractory to high-dose steroids, ACTH injections used to be given years ago. Now it came back in vogue again. It used to be only before all these other drugs. My sister-in-law's mom used to do ACTH injections at home. My sister-in-law used to give them to her. MS symptoms, chronic or ongoing indicators of MS damage, lesion damage to certain parts of the brain. So like I was saying in that previous slide, when we had those cuts of the brain tissue, so depending upon where the lesions are, that's what gives you the cognitive loss, the emotional disinhibition, the optic neuritis, the vertigo, the bladder problems. So, a trained person who can look at these images and then connect the dots, we just know these things exist, and then our focus of our treatment is to help with symptom management. Reducing symptoms so they can function. We have people that work full-time that have MS. We have people that are disabled from their MS. The goal is to improve their quality of life and avoid other complications. Symptom cycles that can occur, the fatigue is a big problem. 80 to 90% of them report a bone-crushing fatigue that is different just than tiredness and malaise and things that we all get. They have cognitive impairments. They have problems with sleep, which seems to be underdiagnosed and not addressed, at least not. So if you can think about these things in this population, spasticity, constipation problems, exercise intolerance, heat intolerance, dizziness. So what do we do to help them? We communicate with them, we educate, we help them with exercise programs. If you don't know what to do, Google the MS Foundation. We have a Wisconsin chapter. Provide professional support. There's pharmacological and non-pharmacological intervention we can do. There's MS walks, MS bike rides. A friend of mine's husband's had MS since he was 17. His legs don't work. He knows it. He is 60 years old now. He worked until he was 48 or 50. But he's wheelchair bound, but he does hand cycling. And he wants to do that competitively. I'm not going there with them, but that's his aspiration now. So fatigue may appear early. It may come on and attack easily without warning. And I'm talking about not being able to get out of bed, not being able to function. That leads to increased depression. Depression's a big thing with these folks. Their physical limitations. It's a young population. They are tired, up to 95%. But you have to look at, do they have hypothermia? Is it the depression? Is it anemia? Chronic heat exposure? Sleep obstruction? Pulmonary dysfunction? So what do we do to help them with that fatigue? We change their lifestyle. We help them to do things, tricks to not expend so much energy. Pharmacological, we mentioned amantadine in a previous talk for energy. In the Parkinson's, it does work. Modafinil, you may have heard of, also known as Provigil. There's a longer acting called Nuvigil. Those sometimes sometimes some of the Schedule II stimulants, Adderall, Ritalin. We try to give them energy, even though artificial. It helps to keep their cognitive more sharp and also to not be so tired all the time. By no means is it a cure, it just helps symptom management. Antidepressants have also been used with some success. Sleep issues, we live in, I mentioned that a few talks ago. Some studies have shown sleep disorders are affecting as many 70 million people in the U.S. I bet there's some in this audience listening to this right now that have that problem. 20% of the general population in MS is as high as 54%. Apnea, insomnia, and restless sleep. fatigue, I said, is made worse with their sleep-related issues. As opposed to depression and fatigue, sleep problems in MS can be qualified by a sleep study. You know, we now have those apnea links you can take home. I've had patients take home the pulse ox overnight. If I'm like, they don't want all this elaborate stuff, but I have to see what's going on, the quality of their life can deteriorate, and it's a long under-recognized issue. And I read about this again and again and again in this population, the sleep. So they get hypersomnias, they're tired all day long, sleepy, drowsy, want to sleep during the day. They can't fall asleep. They have circadian rhythm disturbances. They have REM parasomnias. They have bad things happen that occur primarily during sleep. I actually work with a sleep psychologist. She tries to do everything possible but medications to get people to sleep if we can possibly do so. So these are just some things that we can do. Hypnotics and lifestyle and narcoleptic stimulants and Mirapex and all those things. But, you know, a referral to a sleep specialist for anybody out there beside our MS population isn't a bad idea. We have 2 board-certified sleep psychologists in the state of Wisconsin, if you didn't know that already, that do non-pharmacological management of sleep if it's not obstructive sleep apnea, but they have anything from REM sleep disorders to circadian rhythm problems. It's very helpful. Depression in the MS patient is pretty prevalent, up to 60%, I would say probably more. You know, 3 to 5% of our general population are depressed, 60% of MS patients. Differs from normal grieving. You know, we go through these grief processes with chronic illness, you know, your new normal, your abnormal normal, your new life. This is how, they're never going to be how they were before. I see that along the spectrum of any chronic illness. But 50% of them get major depressive episodes, and the risk of suicide remains 7.5 times higher than the common in the general population in the MS. And that I verified that through the foundation again before I presented today. Feelings of sad, despair, the typical depressive things we should look for and help these folks out. Anybody with a chronic and neurological or illness in that matter. You know, the stigmatism with depression, you know, you're weak, you're not strong, you can't, you know, the attitude, all that jazz we hear. We have to help people to get through sometimes. Their symptoms can be confused with other MS. Symptoms can be fused with other symptoms. So if you need direction on this, if you ever need to contact me about any of the things I've spoken about, you feel free to get my contact information. This pseudobulbar effect, that is where you laugh or cry inappropriately because of the way your brain is affected. And you think, what the heck? But there is a drug with dextromethorphan and quinidine sulfate, which can be effective for this. Cognitive impairment occurs in 40 to 60% of patients, but results in 15% of patients have significant change. Sometimes it's just short-term memory and impaired judgment, but some people have really learning, word finding, and functional problems. So you sometimes meet your euphoric MS patient. They have no real insight as to how debilitated they are. They just kind of plug along. And then there's other people that have progressed and they have insight into it, and they get very sad and emotional. So they'll have these word finding and finding the right words and difficulty in following directions and trouble with decision making. So I would just keep cognizant of that. I mean, there's a list of things, car accidents, more hours to I hear that a lot, more hours to accomplish a familiar task. Difficulties completing projects and getting things done. The cognitive stuff, you know, neuropsychiatric testing, compensatory techniques, disease-modifying therapies. Spasticity we've all heard about, and we had baclofen, we have tizanidine. Some people go as far as baclofen pumps. for that, there's spasticity. Spasticity, I would caution you, may worsen with an infection, constipation, or temp changes. So what can we do? We can offer non-pharmacological. We can refer to people who in pain clinics who do baclofen pumps. That's my experience. There are neurosurgeons that put them in. Baclofen, tizanidine. I do see myself share of people on diazepam and dantrolene, Dantrium. It's a muscle relaxant, not used as much as it used to be. It's kind of along the line of myceline and primidone. You know, you hear about it, but it's out there. Nerve blocks and Botox is used a lot in spasticity for MS these days. So dalfampiridine was a walking pill that came out to help patients with MS walk for longer periods of time. It was developed and released in 2010. It helps the voltage sensitive potassium, increasing the connections on those damaged axons. I've heard kind of mixed things, but it's opposed to, there's this, when you are in an MS clinic, usually we mark off how they measure patients' progression, improvement, or decline. We marked off in the hallway how fast they could walk 25 feet. And what, according to this, then you have a stopwatch and you time them walking a certain amount. And it would tell us if the modality we're using is helping them or hurting them without keep imaging the brain all the time. So this drug came out to improve that. There's a high rate of non-responders. They say give it a whirl for 2 to 4 weeks. As you can see there are side effects just like there are with other meds, dizziness, fatigue, insomnia, and UTIs, which we try to avoid. Bladder dysfunction is a biggie. I believe I read 80% of patients with MS can have bladder problems. So that's the patient you may see in your office in the primary care setting. The guy or the gal who comes in with the UTI and an exacerbation of MS, it gets difficult. You may have to get urology involved, and it's because of the chronicity and the antibiotic resistance, so on and so forth. But I just wanted to make you aware of that. Some have to do intermittent self-cath. Some are to the point of inhaling catheters. So that's just a word of caution on that note. But we encourage them with bladder, avoid the typical things that make your bladder lining irritated. We do bladder retraining. We have them do various things. The problem line is then people don't want to drink because they don't want to urinate, and then we get into dehydration and all that other stuff. So it's caused by lesions in the spinal cord, not usually in the brain. It's usually in the spinal cord. They get involuntary bowel problems. They get diarrhea. Is more uncommon. The constipation seems to be the issue, and we kind of all know what we do for that, hopefully by now. Because this is a young population, I have to just touch base for dysfunction and intimacy. They have men and women can experience all of these, except the ladies get the vaginal and clitoral engorgement problems. But the bottom and erectile dysfunction, obviously ejaculation is the male. But the bottom line is they can be affected. This in a married or in a couple or a sexually active person, this is a big deal. And it's often not discussed in the clinical setting. And I think sometimes that may be part of their depressive issues too. So you got to look for other reasons, obviously. Then you discuss about strategies, how to manage these things. And does the spasticity, the fatigue, the paresthesia, the bowel bladder problems cause problems with intimacy? Tremor has been observed. That's when the lesions in the brain of are present in the cerebellum, and you can see it in the head. I see a lot more like in the head and limbs when they're pretty advanced. These list some other things, and what's that? Oh, that's true. So they're kind of when you stand up and you're kind of titubation. Yeah, so they don't seem steady, and it's not that they're off balance, but they're tremoring. If I could use that word better. Yes, that's the way I say it. Non-pharmacological things that can help tremor, and some of this we might we'll talk about more tremor in, this is for 8-2, right? 3, we go into in-depth study on tremor management, but these are some of the drugs you might see them using. I have not had anybody with MS get DBS, but I have had patients with Parkinson's and tremor get deep brain stimulation. Pain is another thing with these folks in a limb or arm's leg. What you can do is non-pharmacological. You look to your PM&R people to help you out on that, some physical therapists. You know, always there's going to be medications to try for neuropathic pain, from your tricyclics to your anti-epileptics to the antispasmodics. You know, if it's this will probably be something in the neurology arena, but if you're trying to manage them or you feel they're undermanaged, you know, a pain clinic might be a good way to go. A lot of our pain clinics, as you know, are getting away from narcotics, but some of the more comprehensive programs, they do know how to manage some of this spasticity and pain for these folks. So this was my timeline of approved and emerging MS therapies. And you mentioned which drug?
We just got approval back in June. Oh, yeah, there it is.
The May of 2016, yeah. So this, and the magazine you're reading is from when?
Just September.
September of 2016 as that nurse practitioner?
Mm-hmm.
Yes, so I'm glad I'm up to date.
Yeah.
Because so these drugs, when I gave my lecture, recorded it last, were still in the pipeline. That's the lingo I think the researchers use. They have now been approved as early as February and May of 2016. So there you go. In the last 4 years, we've had 4 major drugs get approved. Yeah. So here's my case study scenario. 59-year-old presents with pains to bilateral feet and legs. She describes, I feel like they are on fire. She has numbness, weakness, tingling, worse with activity and weather and temperature. Pains have been there for years and it's getting worse. She also has lack of sensation with bowel movements and urine. Fatigue, sleepy throughout the day, even though she usually gets 6 hours of sleep nightly, which I don't think is enough, but that's me. Has trouble concentrating and short nonetheless. Could this be a typical presentation for MS? Her presentation is true, right? However, her age just falls out of the bracket. So what happens with these scenarios is what I think I want to show up to you is 20 to 50 is the more common age. But when I really looked back, I summarized all these little notes. These were all complaints over the last 9 years building up to now. Or could I take that back? Maybe building up to the last 3 years. She started some other things since then. What other differential diagnosis would you consider? So you might think, does she have neuropathy? Does she have fibromyalgia? Does she have depression, insomnia, chronic pain syndrome? You got to think about all that. Who knows? These people come in and they kind of overload you sometimes. So which of the following are potential triggers for MS? Except, so we know genetic disposition could be environmental exposure and infectious. We don't think we get it from medication. The goals of MS are all of the following except treating relapses, managing symptoms, modifying or reducing progression, and facilitating acceptable quality of life. We would never encourage a patient to exercise in extreme heat. So diagnosing MS would include clinical diagnosis, requires an abnormal MRI, dissemination over space and time. And what that really means is when you're listening to the history, so they say, I lost vision in my right eye, but it came back right away. But the next time it was for half a day, and the next time. So you have to think about optic changes. And they have there's no other explanation for this. The MRI is the gold standard now. It used to be the spinal tap, the MRI, the evoked potentials. but they all go off the MRI. So that's the end of my discussion on multiple sclerosis today. Thank you for your time and attention.